welcome to this presentation on acute agitation. It's really me focus mostly in the emergency department, but though the concepts can be, it will be applied everywhere. I'm Jimmy Pruitt, an emergency maximum clinical pharmacist, and I also make content for Foreign Software Podcast and PACU. And super excited to really dive into this. And I'm hoping that whether you're a provider, pharmacist, a nurse, this presentation is going to really focus on cases and have some questions you will be able to get some more information on. So let's go ahead and dive right into it. All right, so before we jump into the content, let's go over our learning objectives for today. By the end of this presentation, you should be able to evaluate the efficacy, onset, and safety of oral pharmacologic agents for managing mild agitation in the emergency department. Compare the differences in onset, efficacy, and safety between first-generation and second-generation antipsychotics for managing moderate to severe agitation. Assess the efficacy and safety of monotherapy versus combination therapy, that's antipsychotic plus benzodiazepine, in treating moderate to severe agitation. And finally, evaluate the evidence supporting the use of ketamine for severe agitation. We'll also compare its onset, efficacy, and safety to more traditional sedatives like antipsychotics and benzodiazepines. These are the core areas we'll cover as we move through the presentation. All right, just a quick note on disclosures. There are no relevant disclosures related to this presentation. However, we will be discussing the off-label use of some medications, and all of that will be supported by clinical literature. So let's talk about why managing acute agitation is so critical in the emergency department. First, it's something we see all the time. There are around 12 million ED visits every year related to mental health disorders. And with that comes a high incidence of violence in the ED. In fact, up to 71% of ED providers have witnessed violence in the workplace. Now, this ties into workplace safety concerns. Around 25% of ED staff report feeling unsafe at work. Agitated patients present a real risk, not just to themselves, but to the staff and other patients. That's why timely intervention is so important. Early intervention can reduce the risk of physical harm, the trauma of using restraints, and it can even shorten prolonged ED stays. Ultimately, managing agitation effectively improves overall outcomes. It allows us to provide timely medical care and appropriate psychiatric treatment for our patients. Now let's look at the epidemiology of acute agitation in the ED. It's more common than we might think. About 1 in 8 ED cases involve some form of agitation, and that often leads to violent behaviors. Acute agitation typically presents in patients with underlying psychiatric disorders or substance use issues, especially things like alcohol and stimulant use. These contributing factors play a big role in why we see so many agitated patients in the AD. And if a patient over 40 suddenly starts showing new psychiatric symptoms, it's much more likely those are linked to an organic cause. Now the impact on our resources is significant. Agitated patients need more staff attention and often delay other critical care. So it's clear that managing agitation effectively can have a direct impact on overall ED efficiency. Now, the impact on our resources is significant. Agitated patients need more staff attention and often delay other critical care. So it's clear that managing agitation effectively can have a direct impact on overall ED efficiency. So let's dive into the clinical presentation of acute agitation. What does it actually look like when these patients come through the ED doors? First, we're talking about physical aggression. Imagine a patient who's shouting, arguing, maybe even threatening staff or other patients. But it doesn't stop there. You might also see them lashing out physically, hitting, kicking, or even just being physically combative without much provocation. It's like they've lost control of their movements, thrashing, hyperactive, resisting every instruction you give without thinking about the consequences. It's the kind of behavior that can escalate quickly if we're not prepared to intervene. Then we move into the behavioral disturbances side of things. And this is where we see irritability that can spike into full-on emotional swings, going from calm to furious in seconds. It's like flipping a switch. 1 minute they're cooperative, and the next they're completely overwhelmed by their emotions. And in more severe cases, we might see something called agitated delirium which often happens when there's substance abuse or a psychiatric breakdown in play. That's when the situation gets really dangerous, not just for the patient, but for everyone involved. So keeping an eye out for these symptoms is crucial in spotting and managing acute agitation before it escalates. So now that we've talked about how acute agitation presents, whether it's physical aggression or those sudden mood swings, let's look at why it happens. What's going on under the surface that drives this kind of behavior? First up, we have psychiatric disorders. Many of these patients are dealing with acute exacerbations of conditions like schizophrenia, bipolar disorder, or other severe mental illnesses. It's these flare-ups that can really push a patient into that heightened state of agitation. In elderly patients, especially those with dementia, delirium is a huge factor. You'll often see that these patients become disoriented and in turn agitated as they lose touch with their surroundings. And then there are substance-related causes. We all know that alcohol intoxication or withdrawal, along with stimulant use, things like cocaine or amphetamines, can lead to serious agitation. But it's not just about the substances themselves. There are metabolic syndromes like neuroleptic malignant syndrome or serotonin syndrome that can emerge often as reactions to medications, and they can rapidly escalate into life-threatening situations if not addressed. Finally, we have medical conditions that contribute to agitation. Things like intracranial infections, trauma, low blood sugar, and hypoxia, lack of oxygen, can all set off agitation. These are underlying causes we can't overlook, especially when the agitation seems to come out of nowhere. Understanding these drivers helps us get to the root of the problem, which is key for effective treatment. All right, so once we've identified that a patient is agitated, the next step is evaluating just how severe that agitation is. We do this through a combination of clinical observation and some objective tools. First, let's start with clinical observation. We assess the patient's behavior, things like verbal threats, physical aggression, or even just restlessness. And it's important to keep in mind the bigger picture. Are there environmental factors at play? Is the patient under the influence of substances, or are there underlying medical or psychiatric issues? Once we've done our initial observation, we can move on to objective measures. One tool we use is the Rapid Agitation Management Scale. This helps us quickly assess the patient's behavior and determine the immediate risk of violence. And of course, monitoring vital signs is crucial. We need to keep an eye on their heart rate, blood pressure, and respiratory rate to get a full picture of their condition. Together, these steps give us a comprehensive assessment of the patient's agitation so we can tailor our intervention accordingly. So, after evaluating the patient's agitation, we often turn to standardized assessment scales to quantify its severity. These tools help us get a more objective understanding of the patient's condition. Let's take a quick look at 3 of the most common scales we use. First, there's the PANS-EC, or Positive and Negative Syndrome Scale, excited component. This scale is designed to assess positive symptoms like excitement and hostility, and it's particularly useful in cases involving schizophrenia-related agitation. Next, we have the BARS, or Behavioral Activity Rating Scale. It measures agitation severity on a 7-point scale, from full sedation to extreme agitation. And this gives us a clear picture of where the patient falls on the spectrum. Lastly, there's the AMS, or Agitation Calmness Evaluation Scale. This one ranges from unarousable to severely agitated, and it's often used to gauge sedation depth in patients. Each of these scales gives us a structured way to assess agitation, which is crucial for tailoring our treatment plan. Now that we've reviewed the assessment scales, the next step is to assign a level of agitation, mild, moderate, or severe, based on both the scale results and our clinical judgment. Let's start with mild agitation. And these patients are usually cooperative, but you will notice restlessness or irritability. In many cases, they respond well to verbal de-escalation techniques or oral medications. Moderate agitation is where things start to escalate. Patients might exhibit physical aggression or flat-out refuse to follow commands. In these cases, you'll often need to use IM or IV medications to control the agitation. Finally, we have severe agitation, like these patients that display violent behavior that poses a danger to themselves or others. At this point, chemical sedation or physical restraints may be necessary to ensure safety. So, determining the level of agitation helps guide how we manage these patients, from less invasive interventions in mild cases to more aggressive approaches in severe cases. All right, let's dive into a case study to explore how we might manage mild agitation in the ED. This is John Doe, a 45-year-old male who weighs about 80 kilograms. His medical history includes hypertension, type 2 diabetes, and an anxiety disorder. John's family brought him into the ED because he's been increasingly irritable and restless over the last 48 hours. He's been verbally confrontational at home, but importantly, he hasn't shown any violent behavior. And during our assessment, we find that John is likely experiencing mild agitation, which may be triggered by a combination of factors, namely non-adherence to his SSRI medication, along with increased work-related stress. He's clearly distressed and irritable, but there's no immediate danger to himself or others. So here's our clinical question. What are the safest and most effective options for managing John's mild agitation? So in managing John's mild agitation, let's start by looking at non-pharmacological strategies. These methods often help de-escalate situations without the immediate need for medications. First, we can focus on verbal de-escalation. By using calm, simple language, we can reduce his anxiety and prevent escalation. Respecting his personal space and offering him choices can also help, giving him some control over the situation. Next, we'll want to make some environmental modifications. This could mean placing him in a quiet, non-stimulating environment to reduce any sensory overload and removing any potentially harmful items that could escalate the situation. Finally, when it comes to physical restraints, we should only use them as a last resort. Early use of calming techniques and offering medications voluntarily will often prevent the need for restraints. These non-pharmacological methods are the first step in addressing John's agitation. Now let's focus on one of the most important non-pharmacological strategies of verbal de-escalation. This is often the first line of defense when dealing with mild agitation, like in John Doe's case. First, we need to maintain personal space and use effective body language. A good rule of thumb is to stay about 2 arms lengths away from the patient. This distance helps ensure both their safety and ours. For example, if John Doe starts pacing or seems physically restless, giving him space rather than standing too close can make a big difference. We also want to keep a non-confrontational posture, standing at an angle, not directly facing him, and avoiding direct eye contact. These subtle changes can help diffuse tension. Let's talk about setting clear limits and offering choices. It's important to clearly communicate that certain behaviors, like violence, won't be tolerated, but at the same time, give the patient choices to help them feel more in control. For instance, you could say, "I understand you're feeling frustrated. You can either sit down here, or we can move to a quieter area where you might feel more comfortable." This avoids a power struggle and instead focuses on mutual understanding, helping the patient regain control over their emotions. These verbal de-escalation techniques are crucial in managing agitation before the situation escalates, and they often reduce the need for more invasive interventions. Now let's talk about environmental modifications, adjusting the patient's surroundings to prevent agitation from escalating. One key step is to reduce stimuli in the environment. Agitation can be triggered by loud noises, bright lights, or too much chaotic movement around the patient. For example, moving the patient to a quieter room, away from other agitated or provoking individuals, can help calm them down and prevent escalation. We also need to ensure safety in the environment. This means removing items that could be used as weapons, things like medical equipment or even sharp objects. Additionally, we want to make sure there's easy access to exits for staff safety and that we're closely monitoring the patient to prevent any self-harm or harm to others. By managing the environment, we can significantly reduce triggers and maintain safety for both the patient and staff. So let's now discuss the use of physical restraints, which should only be considered when verbal or non-pharmacological strategies have failed. Restraints should be reserved for situations where the patient poses an imminent danger to themselves, others, or the environment. Before we reach this point, it's crucial to exhaust verbal de-escalation techniques and, when appropriate, chemical sedation to help calm the situation. When it becomes necessary to use physical restraints, The application must be handled carefully. Restraint should only be applied by a trained team following a clear protocol to ensure the patient's safety and to prevent any injury. Once the patient is restrained, it's critical that we continuously monitor them to watch for complications, things like respiratory depression or neurovascular damage. Using restraints is always a last resort, but when done properly, it can prevent harm while allowing for more controlled management of agitation. Now, when using non-pharmacological techniques such as physical restraints, it's important to consider a few precautionary measures. First, physical restraint should only be used when the patient poses an immediate danger to themselves or others. It's crucial that proper communication among the team is in place and the staff is trained to apply restraint safely. Next, ongoing monitoring is essential. This includes checking vital signs like heart rate and respiratory function, as well as keeping an eye on any physical complications such as circulation issues or skin irritation. We also need to consider the patient's psychological well-being during this process. Lastly, remember to explore alternatives before resorting to restraints. Verbal de-escalation techniques and environmental adjustments can often help diffuse a situation. Additionally, offering voluntary medications or using calming techniques can be beneficial in preventing the need for restraints. Now let's wrap up John Doe's case by looking at how our non-pharmacologic strategies helped resolve his agitation. First, we saw success with verbal de-escalation techniques. By offering John choices, maintaining a calm and composed demeanor, and respecting his personal space, we were able to lower his anxiety levels. This approach helped reduce his agitation without needing any pharmacological intervention. Second, we made some environmental modifications. Moving John to a quieter room, away from other stimuli, and removing potentially harmful items from the area also contributed to calming him down. This prevented the need for physical restraints or further medication. In John's case, using non-pharmacologic approaches like verbal de-escalation and environmental changes proved to be effective. It highlights how these strategies can reduce agitation without resorting to more invasive measures. So now that we've discussed non-pharmacological strategies like verbal de-escalation and environmental modifications, let's shift our focus to pharmacotherapy for managing mild agitation. Specifically, we'll start with oral treatments in the emergency department, which are often used as a first-line approach. The goal here is to evaluate the efficacy, onset, and safety of these oral agents. We'll explore how quickly they take effect compared to other routes and how well they work in calming down patients with mild agitation. And of course, we'll need to consider their safety profiles. While oral agents are generally safer than more invasive treatments, they're not without risk. So we'll take a look at potential adverse effects. Let's dive into the key oral treatments and see how they fit into our management of mild agitation in the ED. All right, let's introduce our case for this section. We have a 45-year-old male presenting to the emergency department complaining of feeling restless and agitated. When we first observe him, he's clearly exhibiting mild agitation. He's cooperative, but he's pacing around the exam room, visibly distressed. His vital signs are fairly normal: a heart rate of 90 beats per minute, blood pressure at 135/85, respiratory rate of 18, and his temperature is 37 degrees Celsius. He's also maintaining a good oxygen saturation at 98% on room air. Now, what's interesting is his relevant history. He's got a history of an anxiety disorder, but he's not currently on any medications for it. He also denies any recent substance or alcohol use, which is important in ruling out other contributing factors. So this is the scenario we're working with: a patient showing mild agitation in the ED. Now let's continue with an update on our case. Our patient's agitation hasn't worsened, but he's still mildly restless. The attending physician decides to try an oral agent to manage the agitation. The goal here is to calm the patient while keeping him alert enough for further interaction and assessment. So here's the question: what are the available oral agents for managing mild agitation in the emergency department, and how do their onset and duration of action compare? Take a moment to think about it. We'll go over this together. All right, now let's go over some of the common oral agents we use for managing mild agitation in the emergency department. First up, we have olanzapine in its oral disintegrating tablet form. Olanzapine works by blocking dopamine D2 receptors, which helps reduce agitation, and also blocks serotonin 5-HT2 receptors, which can help improve mood. The onset of action is fairly quick, about 15 to 45 minutes, and it lasts for 6 to 12 hours. Common side effects include sedation, metabolic changes, and QTc prolongation. Next is risperidone. It also blocks dopamine D2 receptors and serotonin 5-HT2A receptors, which help manage agitation and mood. It takes about 30 to 60 minutes to start working, and the effects last for around 24 hours. But keep in mind that it can cause extrapyramidal symptoms, hyperprolactinemia, and weight gain. Then we have quetiapine, which similarly blocks dopamine D2 and serotonin 5-HT2 receptors. However, the onset is slower, about 60 to 90 minutes with a duration of 6 to 12 hours. Side effects to watch for include sedation, orthostatic hypotension, and weight gain. Another option is asinapine, which is given sublingually. It also works by blocking dopamine D2 and serotonin 5-HT2 receptors. It acts quickly with an onset of 15 to 30 minutes and lasts for 8 to 12 hours, but it can cause sedation, oral hypoesthesia, and extrapyramidal symptoms. Finally, there's lurasidone. This medication takes longer to start working, between 1 to 3 hours, but it lasts for up to 18 hours. It also blocks dopamine D2 and serotonin 5-HT2A receptors, but with a lower risk of sedation and confusion compared to the other agents. However, we still need to watch for extrapyramidal symptoms. Let's continue by looking at a few more common oral agents we use for managing mild agitation, focusing on first-generation antipsychotics, benzodiazepines, and a couple of adjuncts. First, we have haloperidol, a typical antipsychotic or first-generation agent. It works by blocking dopamine D2 receptors, which can help calm agitation but also comes with side effects like extrapyramidal symptoms and the risk of tardive dyskinesia. The onset is about 30 to 60 minutes, but the effects can last anywhere from 10 to 37 hours. Next are the benzodiazepines, starting with lorazepam. It works differently than antipsychotics by enhancing GABA activity, which produces a calming, sedative effect. It acts fairly quickly, within 20 to 30 minutes, and lasts for 6 to 8 hours, though we have to watch for side effects like sedation and respiratory depression, as well as the risk of dependency. And then we have clonidine, which is an alpha-2 adrenergic agonist. Yes, this medication works by reducing sympathetic outflow, essentially calming the fight or flight response. Its onset is similar to haloperidol, around 30 to 60 minutes, but the duration can be variable. Common side effects include sedation, bradycardia, and hypotension. Lastly, there's valproic acid, which can be used as an adjunct therapy. It works by increasing GABA activity and stabilizing neuronal membranes. The onset is a bit slower, taking several hours, and side effects can include sedation, gastrointestinal upset, and the risk of hepatotoxicity. Now let's take a closer look at how these oral agents compare in terms of their onset, duration, and side effects. For instance, olanzapine ODT starts working in about 15 to 45 minutes and lasts for 6 to 12 hours. However, we need to keep in mind side effects like sedation and QTc prolongation, secondary. On the other hand, lorazepam, a benzodiazepine, takes 20 to 30 minutes to kick in, and it lasts for 6 to 8 hours. While effective, it comes with risks of respiratory depression and dependency. When comparing risperidone and quetiapine, risperidone has a 30 to 60 minute onset but lasts up to 24 hours, whereas quetiapine takes longer to start working, about 60 to 90 minutes, and lasts for 6 to 12 hours. Both of these agents carry the risk of weight gain and other metabolic effects. This table helps visualize how each agent stacks up, both in terms of speed and duration, as well as the potential side effects to be aware of. All right, let's kick off this section by looking at why managing moderate to severe agitation is so crucial, particularly in the emergency department. As we know, agitation, if left unchecked, can jeopardize the safety of both the patient and the healthcare team. It's not just about controlling behavior, but doing so in a way that balances efficacy and safety. The common pharmacologic options we'll explore include first and second generation antipsychotics, benzodiazepines, and NMDA antagonists like ketamine. You might also be familiar with combination therapies like B52 or which are often used in these cases. Now let's move on to a case to ground our discussion. We have Jane Smith, a 30-year-old female weighing 70 kilograms presenting with severe agitation. Her agitation stems from both psychiatric illness and substance use, which we see often in our ED settings. Upon initial assessment, we classify her agitation as moderate to severe, and this brings us to a key clinical question. What are the most effective and safe pharmacologic options for managing Jane's agitation? Starting with the first set of options, haloperidol is often a go-to medication for agitation. And when given intramuscularly at doses of 2 to 5 milligrams, it takes around 20 to 40 minutes to start working. However, it lasts quite a long time with a half-life anywhere from 18 to 24 hours. Be mindful of potential side effects like extrapyramidal symptoms and QT prolongation. Another option is droperidol, which works a bit faster with an onset of 15 to 30 minutes, but has a shorter duration of action. Chlorpromazine, while effective, isn't preferred due to its significant sedative and hypotensive effects. Now let's look at the second set of options, primarily benzodiazepines and NMDA antagonists. Midazolam is a popular choice, often administered intramuscularly at doses of 5 to 10 milligrams. It has a rapid onset of 5 to 10 minutes, but a shorter duration, lasting about 2 to 6 hours. Lorazepam, another benzodiazepine, takes a little longer to act, around 20 to 30 minutes, but it has a longer duration, lasting up to 8 hours. Ketamine, on the other hand, is a fast-acting NMDA antagonist. It works within 3 to 5 minutes and lasts about 15 to 25 minutes, but you need to monitor for side effects like emergence reactions and hypertension. So here's an update on our patient, Jane Smith. The initial treatment was intramuscular olanzapine administered at a dose of 10 milligrams. Within 30 minutes, Jane's agitation significantly reduced, and importantly, there were no serious side effects like respiratory depression or excessive sedation. At this point, Jane remained stable, and we're considering transitioning her to oral antipsychotic therapy. However, we need to reassess whether continuing olanzapine is the best choice for long-term management. This brings us to our next critical question. Is there a difference in efficacy and safety between first and second generation antipsychotics in managing moderate to severe agitation? We'll now explore some of the key studies comparing these two classes of antipsychotics. Let's begin by examining the first study, which compared intramuscular olanzapine at 10 milligrams to intramuscular haloperidol at 7.5 milligrams in a cohort of 311 patients diagnosed with schizophrenia. This double-blind randomized trial primarily focused on reducing symptoms of agitation within the first 24 hours using the positive and negative syndrome scale excited component. The findings revealed that olanzapine had a faster onset of action and was significantly more effective in reducing agitation than haloperidol. Additionally, patients treated with olanzapine experienced fewer side effects, particularly extrapyramidal symptoms and cardiovascular issues, which are common concerns with haloperidol. In my practice, I've seen similar results with olanzapine outperforming haloperidol in terms of speed and overall safety. While haloperidol still has its place, especially for immediate sedation, I prefer olanzapine for most cases because of its rapid onset and fewer side effects. I especially appreciate the lower risk of EPS, which is a serious concern when managing agitated patients in the emergency setting. And this study confirms what I've often seen. Olanzapine is my go-to, particularly when there's time to wait for the 10 to 15-minute onset without sacrificing patient safety. Next, we move to the second study, which compared intramuscular risperidone at 1 to 2 milligrams with intramuscular haloperidol at 5 milligrams in patients presenting with acute agitation due to schizophrenia or bipolar disorder. In this double-blind trial involving 95 patients, both medications were found to be equally effective in controlling agitation with similar times to onset of action. However, the key differentiator was the side effect profile. Risperidone resulted in fewer incidences of extrapyramidal symptoms, while haloperidol had a higher rate of EPS but offered faster sedation. The third study we'll review compared intramuscular ziprasidone at doses of 10 to 20 milligrams with intramuscular olanzapine at 10 milligrams in patients experiencing acute agitation due to schizophrenia. This study focused on two primary outcomes: the efficacy in reducing agitation within 4 hours and the risk of cardiovascular side effects, particularly QT prolongation. Both Z-prasidone and olanzapine were found to effectively reduce agitation within the 4-hour window with similar levels of symptom improvement. However, Z-prasidone was associated with a higher risk of QT prolongation, especially in patients with pre-existing cardiovascular conditions, whereas olanzapine had a more favorable safety profile. So let's update the case of Jane Smith. Following the administration of 10 milligrams of intramuscular olanzapine, Jane's agitation has continued to improve without significant side effects. At this point, she remains stable, and we're now considering transitioning her to oral antipsychotic therapy for sustained control. But before we do that, we need to reassess the overall treatment strategy to determine whether a first-generation or second-generation antipsychotic is the best option moving forward. Our next question is whether there's a significant difference in efficacy and safety between benzodiazepines and antipsychotics for managing moderate to severe agitation. This is particularly important for patients like Jane, where psychiatric and substance use factors both play a role in her presentation. We have the Klein and colleagues study from 2018, which compared intramuscular midazolam and intramuscular haloperidol in 737 patients. This was a prospective observational study looking primarily at how quickly each drug achieves sedation, as well as adverse events and the need for additional medications. Let's move to the key findings on the next slide. So what did they find? Midazolam provided rapid sedation within 15 minutes for 71% of patients, performing faster than haloperidol in terms of initial calming. However, haloperidol offered prolonged sedation control beyond 2 hours, so fewer doses were needed over time. This difference is crucial depending on whether rapid or sustained control is the treatment goal. Now, in terms of safety, haloperidol had a higher rate of extrapyramidal symptoms, while severe respiratory events were rare across both treatments. In conclusion, midazolam is preferred for rapid sedation, whereas haloperidol may be the better option when extended sedation is necessary. All right, with that study in mind, let's look at another comparison in the next slide. Next, we have the Meehan and colleagues study from 2021. This randomized trial focused on intramuscular olanzapine and lorazepam in 201 patients experiencing agitation due to bipolar mania. The study sought to evaluate which medication was more effective in reducing agitation quickly and safely. Let's move on to the results. Here, olanzapine stood out, reducing agitation faster than lorazepam within 2 hours, and it continued to show greater improvement in agitation levels even at 24 hours. Additionally, both drugs had similar safety profiles with no major side effects like EPS or QTc changes, indicating a favorable tolerance for both. However, this study had some limitations. It was conducted specifically on patients with bipolar mania, which may limit its generalizability. The authors concluded that olanzapine is effective for rapid control in this context, but they recommended further studies to explore its efficacy across other conditions and to assess long-term safety. All right, before moving forward, let's quickly recap. So far, we've seen that midazolam provides rapid sedation but is short-acting, while haloperidol offers prolonged control. On the other hand, olanzapine has demonstrated faster and sustained control of agitation with a strong safety profile, particularly in bipolar mania cases. Now, looking at safety, antipsychotics generally carry a lower risk of respiratory depression than benzodiazepines, which is a critical consideration, especially for high-risk patients. However, benzodiazepines come with fewer extrapyramidal symptoms compared to certain antipsychotics. So, in summary, antipsychotics tend to be the preferred option for sustained sedation with fewer respiratory risks, while benzodiazepines are highly effective for rapid, short-term sedation needs. All right, here's a clinical case for us to consider. A 45-year-old male with a history of schizophrenia and recent alcohol withdrawal was admitted to the emergency department in a state of severe agitation. He was initially treated with IM haloperidol at 5 milligrams, which partially calmed him within 30 minutes, but he continued to experience restlessness requiring additional intervention. The patient responded partially to haloperidol monotherapy, showing some lingering agitation but no respiratory or cardiovascular side effects. Given this, there's a consideration about whether adding a benzodiazepine to his treatment plan could improve control of his agitation without increasing adverse events. This case highlights a common clinical challenge, balancing effective sedation with safety, particularly in patients with complex medical histories. So, considering the case, what is the efficacy of using monotherapy with antipsychotics versus combination therapy, combining an antipsychotic with a benzodiazepine for managing severe agitation in patients with complex medical histories? First, we have the Yap and colleagues study from 2017, which looked at a combination of midazolam and droperidol compared to haloperidol alone. This randomized, double-blind study found that the combination achieved faster sedation with fewer patients needing additional doses. The conclusion? Combination therapy with midazolam and droperidol is effective for rapid sedation, though respiratory monitoring is essential. Now let's look at another study. Next up is the Huang and colleagues study from 2015, which compared intramuscular olanzapine to a combination of haloperidol and lorazepam in patients with acute schizophrenia-related agitation. Both approaches were effective in reducing agitation, and importantly, there were no significant differences in adverse events between the two groups. This suggests that IM olanzapine could be a safe, effective alternative to combination therapy. Now, looking at agitated delirium in patients receiving palliative care, the Hoy and colleagues study from 2017 found that adding lorazepam to haloperidol provided greater reduction in agitation within 8 hours compared to haloperidol alone. This was particularly helpful in improving patient comfort with manageable side effects. So, in palliative settings, combination therapy may be especially beneficial. All right, to answer our question, combination therapy like midazolam with droperidol can provide faster sedation but does carry respiratory risks, so careful monitoring is needed. Monotherapy, such as olanzapine alone, is safer for patients at higher respiratory risk but may not act as quickly. Choosing between these options depends largely on the patient's immediate sedation needs and their overall risk profile. Now let's review the follow-up for our case. Following a partial response to an initial 5 mg dose of IM haloperidol, the patient was given an additional dose of lorazepam at 2 mg to improve agitation control. This combination therapy successfully reduced restlessness without causing respiratory or cardiovascular complications. The patient showed a full calming response after the lorazepam was added, suggesting that combination therapy can enhance efficacy in managing severe agitation. If his condition remains stable, the plan is to transition him to an oral antipsychotic for ongoing management and to closely monitor for any delayed side effects. This approach highlights the importance of individualized follow-up in complex cases. Let's now review a summary of the pharmacologic agents we've discussed, focusing on their doses, onset of action, duration, and key risks. Haloperidol, a first-generation antipsychotic dosed intramuscularly at 5 to 10 milligrams, with an onset time of 20 to 40 minutes and lasting 10 to 37 hours. The key risks are extrapyramidal symptoms and QT prolongation. Droperidol, another first-generation antipsychotic, given at doses of 2.5 to 10 milligrams intramuscularly, with an onset time of 15 to 30 minutes and duration of 2 to 4 hours. Risks include sedation and QT prolongation. Olanzapine, a second-generation antipsychotic dosed at 5 to 10 milligrams intramuscularly, with an onset time of 15 to 45 minutes and duration of 6 to 12 hours. Sedation and hypotension are key risks here. Ziprasidone, another second-generation antipsychotic given at 10 to 20 milligrams intramuscularly with a similar onset to olanzapine, but comes with the risk of QT prolongation, making it more suitable for patients without cardiovascular risks. Midazolam, a benzodiazepine administered intramuscularly at 5 to 10 milligrams with an onset of 5 to 10 minutes and lasting 2 to 6 hours. The major concern is respiratory depression. Lorazepam, another benzodiazepine with a slower onset of 20 to 30 minutes but a longer duration of 6 to 8 hours. Again, respiratory depression is a concern. Ketamine, a rapid-acting NMDA antagonist given at 2 to 5 milligrams per kilogram intramuscularly with an onset of 3 to 5 minutes and lasting about 15 to 25 minutes. Side effects like emergence reactions and hypertension are important to watch out for. So where does this leave us in terms of treatment recommendations? Monotherapy for moderate agitation, intramuscular droperidol, olanzapine, or Z-prasidone are sufficient, providing effective control with fewer risks of respiratory issues. Combination therapy for severe agitation, a combination of droperidol plus midazolam is preferred over B52, primarily because it has fewer respiratory complications and a faster onset. And here is a list of key references that supported the studies and findings we discussed. All right, we're diving into severe and violent agitation management, particularly focusing on ketamine. As you all know, pharmacologic interventions in these cases are essential for the safety of both the patient and the staff. Now, we traditionally rely on antipsychotics and benzodiazepines, but recently, ketamine has become a preferred choice. Why? Its rapid action and dissociative effects make it uniquely effective when time is critical. Now let's look at this case. Imagine a 35-year-old male presenting with violent behavior. He has a history of schizophrenia, substance abuse, and hypertension, arriving combative and restrained. Here's the challenge. How do we sedate this patient rapidly while minimizing the risks? This is where ketamine's role comes into play. All right, let's take a step back and review the pharmacologic options. We have several choices. Antipsychotics like haloperidol, benzodiazepines like lorazepam or midazolam, and of course, ketamine. Each of these has its advantages and limitations, but as you'll see, ketamine offers the fastest onset, which can be crucial in high-risk scenarios. So in this case, after administering ketamine at 4 milligrams per kilogram intramuscularly, the patient stabilizes. No additional medications or restraints are needed, and this is an ideal outcome: rapid sedation with minimal interventions. Now, we monitor for any cardiovascular or emergence phenomena, and transitioning to less intensive sedatives is the next step if the patient remains stable. Now, what are the evidences supporting the use of ketamine for severe agitation in the emergency department, and how does it compare to traditional sedatives in terms of onset, efficacy, and safety? Let's look at some data. A randomized clinical trial compared ketamine to a midazolam haloperidol combination. What stood out? Ketamine achieved sedation in a median time of 5.8 minutes compared to nearly 15 minutes for the combination group. And that's a significant difference when dealing with violent agitation. However, we did see a slightly higher incidence of serious adverse events with ketamine. In another study, ketamine was pitted against a combination of haloperidol and lorazepam. Here, 22% of patients sedated with ketamine achieved sedation within 5 minutes, compared to 0% for the combination group. By 15 minutes, 66% of ketamine patients were sedated, as opposed to just 7% in the other group. Clearly, ketamine works much faster. Now, despite some transient side effects like hypertension and tachycardia, the safety profile remains solid. Now, returning to our case, the patient remains calm 15 minutes post-administration, vital signs are stable, and there's no sign of returning agitation. Next steps involve monitoring for any adverse effects and considering a transfer to a psychiatric facility. Overall, ketamine has provided the rapid sedation we needed. Now, what are the safety concerns and adverse effects associated with ketamine use in severe agitation, particularly in the emergency department and pre-hospital setting? Now, here's a study by Olives and colleagues in 2016. This study examined intubation rates and outcomes in profoundly agitated patients treated with ketamine in an urban pre-hospital environment. The findings showed that a significant 63% of patients require intubation upon hospital arrival, with adverse events like hypoxia in 21% and laryngospasm in 8%, particularly in those receiving higher ketamine doses. These results highlight the need for consistent dosing protocols in pre-hospital settings and emphasize the importance of being prepared for airway management. Standardizing practices could help minimize some of the risks associated with pre-hospital ketamine administration. Next, we have the Burnett and colleagues study from 2012, which looked at ED experiences with patients administered ketamine before hospital arrival. This case series involved 13 patients and found that rapid sedation was achieved in under 10 minutes for all cases. However, 23% of patients required airway intervention due to complications like hypoxia and laryngospasm. And the study also observed emergence phenomena in 30% of non-intubated cases. Based on these outcomes, the authors recommend co-administration of benzodiazepines to manage emergence reactions, along with ready access to advanced airway tools in the ED. Now, Mankiewicz and colleagues' study from 2018 provides a systematic review and meta-analysis on ketamine for agitation, covering over 650 patient encounters. The review found that, on average, sedation was achieved in around 7 minutes, though intubation rates varied significantly by setting 30% in ground EMS, 8% in the ED, and around 5% in air medical services. Adverse events were common, including hypertension in 12%, emergence reactions in about 3.5%, and transient hypoxia in just under 2%. These findings underscore the importance of setting specific protocols and the potential for lower doses to reduce risk in pre-hospital situations. Standardized monitoring procedures could improve outcomes across various settings. To bring it all together, here's a summary of key findings across the ketamine studies. We see high intubation rates, particularly in pre-hospital settings, due to factors beyond just dosing decisions, as shown by Olives and colleagues. Burnett and colleagues highlighted the need for advanced airway management tools in the ED, given frequent respiratory complications, while the Mankiewicz review emphasized the importance of tailoring ketamine use by setting to reduce adverse events. These studies collectively point toward the value of protocol standardization and patient monitoring to improve safety and effectiveness when using ketamine for rapid agitation control. Finally, let's look at the resolution for our case. The patient's agitation was effectively managed with ketamine, resulting in rapid sedation and stabilization without any serious side effects. The next steps involve transferring the patient for psychiatric evaluation and considering long-term management options such as oral antipsychotics based on his psychiatric history and current stability. This case highlights how ketamine, when carefully monitored, can be a safe and effective choice for immediate agitation control, especially for complex cases needing fast intervention. One last point to cover: how ketamine affects the overall length of ED stays. Research shows that using ketamine for rapid sedation reduces the need for prolonged physical restraint and decreases the time spent in the emergency department. Faster sedation means quicker stabilization, enabling us to move patients more efficiently through the system. To summarize, ketamine offers rapid, reliable sedation with a favorable safety profile in controlled environments. Antipsychotics and benzodiazepines are effective but slower and come with their own risk. Dystonia and respiratory depression being notable concerns. In high-risk, fast-paced emergency situations, ketamine is clearly the superior option. And finally, to resolve our case, the patient's agitation was successfully managed with ketamine, achieving rapid sedation and stabilization without serious side effects. The next steps include transitioning the patient for psychiatric evaluation and considering long-term management strategies, such as oral antipsychotics based on his psychiatric history. Ketamine has served its purpose here, allowing for safe, efficient care. And here are references that supported the studies and findings we discussed. All right, so let's bring everything together. As we've seen, the approach really depends on the severity of the agitation. Non-pharmacologic strategies like verbal de-escalation and creating a calm environment should always be our first step. These techniques help in mild cases, but, they aren't always enough. Now, when it comes to mild agitation, oral agents like olanzapine ODT or risperidone are typically our go-to options. They provide symptom control without heavily sedating the patient, which is key when you still want to engage with them. So, what happens when things escalate to moderate or severe agitation? Well, in these cases, we often need to turn to intramuscular options like haloperidol or lorazepam. They work faster, but you do have to watch out for side effects like sedation and extrapyramidal symptoms. Okay, but what about when the patient is really, severely agitated, violent even? This is where ketamine shines. It works in just a few minutes and keeps the airway stable, which is, of course, critical. But there's always a but. We have to closely monitor for things like hypertension and respiratory issues. For the key takeaways. First off, non-pharmacologic methods should always be attempted first. These are safer and can de-escalate the situation without medication. For mild agitation, oral agents like olanzapine ODT and risperidone are preferred. They give us control while allowing the patient to stay alert. When you've got moderate to severe agitation, intramuscular options like haloperidol and lorazepam are needed, but as I said, keep a close eye on those side effects. Now, when dealing with violent or severe agitation, ketamine offers a fast-acting solution with fewer respiratory risks, but again, it's all about monitoring for potential complications. Next, in some cases, combination therapy like droperidol with midazolam might give you quicker control, but it comes with its own set of risks, especially for respiratory depression. And lastly, patient safety comes first, and your choice of intervention really hinges on the level of agitation in the clinical context.